I'm Dr. Tom Cheatham. I'm a family physician, and I've spent 3 decades providing primary care to people with intellectual and developmental disabilities, predominantly adults. In this one of 2 presentations, I want to take you through a tool, and this tool is for primary care providers, to really answer that question of where do I even start with this person who's presenting with challenging behavior. So I'll step you through this, and the first section just is some basic demographic information, but it's things like etiology of the intellectual disability. That's terribly important because often it's possible to generate a differential diagnosis just based on the etiology. Is there any family history? Of course, that's important. A checklist of additional issues that could be very important. For example, autism spectrum disorder, or vision or hearing impairments, or other disabilities, if there's known previous trauma. And then in this section is also the question about level of intellectual disability. Someone with a mild disability is quite different from someone who has a severe or profound disability. An example there, one I use often, is epilepsy, that at a mild intellectual disability, about 1 in 5 people have epilepsy. As we get to the profound end of the continuum, it's about almost 1 in 2. And then there's this little graphic that, although it seems simple, really hits some of the essential points and is designed to prevent that immediate response of perhaps thinking about a psychotropic drug to help control the behavior when that may or may not be appropriate. Often it's not appropriate. So there are 4 basic questions here. Is this a medical problem? Is it a problem with supports or expectations? Is it a problem in the emotional area? Or lastly, is it a psychiatric issue, one for which psychotropic medication would be appropriate? The next section is a fairly detailed list of possible medical conditions. This is the provider's checklist, after all. One of the areas to highlight is pain. Very easy to miss painful conditions, and if the person has a limited repertoire of expressing whatever they're feeling, it may come out as challenging behavior, when in fact what's important is finding that painful condition and treating it. The behavior then goes away on its own because you've treated the cause. There's some specifics listed here, things like a fracture, tooth abscess, constipation. Constipation's extremely common. Fracture is easily missed because in a person who can't easily identify where the pain is, you may end up having to, first of all, have a low threshold, and then secondly, x-ray more if you're suspicious of a fracture than you would when you could do an examination and be pretty sure of where that fracture might have occurred. Then there's a whole host of other conditions, just as a reminder of some common things, including things like sensory discomfort and gastroesophageal reflux disease, things that we've highlighted in other presentations as very common in this population. Then we move on to the area of supports and expectations. And through the next couple of sections, this is really a place to essentially abstract what the caregiver has provided. What about changes in the person's environment, at school, their work, their day program that is resulting in behavioral change? Does the person have sufficient behavioral supports? So you see a list there of a number of these. And then also highlighted on the provider's checklist here is really a nod to the expectations of those caregivers, be paid caregiver or family caregiver. Are the expectations, do they seem reasonable? Do they overestimate or underestimate the person's ability? Both can cause difficulties. Then the next section is emotional issues, and simply a section to summarize what the caregiver has provided in the companion tool. Next, we look at possible psychiatric disorders. Is there a history of a psychiatric disorder? And it's always worth remembering that a person may have several diagnoses, and I half-jokingly often say some of them may even be true. And that's not trying to be negative towards any colleagues who make diagnoses, but I think of how challenging it is to have confidence in those diagnoses, and I'm referring to myself here. So you need to take those diagnoses with a grain of salt and try to figure out what evidence was used. An example there might be an adult with Down syndrome who is engaged in self-talk. Initially, that looks like possible hallucinations. 2 points. One is we know people with Down syndrome are a little more likely to engage in self-talk. And secondly, if you're seeing someone in an adult-sized body, it's important to remember that from a developmental perspective, think of someone much younger, and it wouldn't seem unusual for a child to engage in self-talk. Past admissions can be helpful if you can get records, but again, those diagnoses are certainly worth reviewing, but view them with a little skepticism. The last section on this page deals with basically a place for you to make your notes. Although we've endeavored to provide checkboxes as much as possible to make the completion easy, no tool can cover everything. So here's a place for your notes. A critical piece is the last page of this tool, and it's the management plan. And if, especially primary care providers, but others as well, if they haven't a lot of experience providing support, healthcare supports to people with intellectual and developmental disabilities, there are going to be elements on this plan you may not think about. So it's a way for you to organize your thoughts and where you're going next. Assuming you were able to do a physical examination on this visit, what were the findings there? What investigations might you want? Highlight any risks that you need to be aware of and any medications to review. Now, clearly this isn't a medication list because it's too small. These are your notes to yourself as part of a plan. And then referrals, and it's a whole host of referrals, and with a very complex person, it may require several disciplines, behavior analyst, speech-language pathologist around communication, occupational therapist, physical therapist, and so on. It may be helpful to do genetic testing. If the testing was done some time ago, there have been huge advances. And knowing some of those components can be extremely helpful. A psychiatric consultation, and so on. Then some strategies to de-escalate the behavioral issues. Think about how that can happen, some supports, any medications that might be used in those circumstances. So this is a plan not only for you, but the entire group of people who support that person. Looking at resources that are available and a focus on target behaviors. Other presentations in this series will expand on a number of those. And then a written crisis prevention and management plan. And we're fortunate in Tennessee in the last few years that we've developed cross-system crisis plans. So that involves the mental health system and mobile crisis and a whole variety of partners who need to come together with the most complex people. And then a place to look at medications in more detail. So this is a helpful plan to organize your thoughts and at least feel like you're making a wonderful beginning to help this person with their challenging behavior. Thank you very much.